now. This is Dr. Amrit Nasta, and he is a leading bariatric surgeon in Mumbai. And along with that, he is one of the biggest faculties of surgery in India. So, as you all know, he takes classes for final MBBS students for surgery. He is the surgery faculty for Cerebellum Academy, and he's also the surgery faculty in conceptual surgery. Along with that, I forgot to add one of the most important things, that he's also my husband. And where did the idea for this interview come about from? So, generally, so we don't work together. But when I go back home and we discuss our day, there are many days that we discuss what happened in the OT and how could it have been managed better. Of course, as an anesthetist, I love to crib about surgeons. So I crib to him and he gives me a perspective of why the surgeon did what he did. And also, the most important thing that I have carried in so many years is he tells me what he expects from his own anesthetist. So that has helped me develop some qualities as a good anesthetist, because I always, whenever I do a case, I always think, okay, what does the surgeon want from me? What will make him call me for his next few cases? And what is he actually thinking about me? Now, all of us definitely feel that अरे surgeon ने ऐसा बोला वैसा बोला कुछ गलत बोल दिया हमारे बारे में, but at the end of the day we are all trying to understand what is the surgeon's perception of us. Is he going to call us next time for the case? Does he think the anesthesia was good enough or not? And that is why we are having this very important session to read into the mind of a surgeon, of what do they want from an anesthetist, what do they expect from an anesthetist, and how do they judge an anesthetist. Now, I know no one should be judging anyone, but it is a human tendency. Even we tend to judge our surgeons based on how much time they are taking for surgery, or if they are, how they are performing the surgery, how much noise are they making during the surgery. And it goes likewise for the surgeons. So, without wasting much time, let's dive into the mind of a surgeon, of what do they think about an anesthetist and what do they expect from an anesthetist. So, welcome, Dr. Amrit.
Thank you, Dr. Janvi, for that wonderful introduction where you missed out the main part and mentioned that in the end about how living with an anesthetist. But let me clear one point. We don't work together. In fact, we have never worked together. So I have no idea how good or bad she is in the OT as an anesthetist, nor does she know about my surgical skills. So whatever we share is all based on our own experiences, which can be a little biased. But yeah, it's better this way because our minds work very differently. Like what she will see in a surgery and what I see in a surgery is very, very different. So hopefully, whatever we discuss today will open your eyes and minds. I believe most of the people here are going to be anesthetists listening. So it
Yes,
will definitely give you an edge over the others when it comes to surgeons choosing anesthetists for his preferential cases, right? So you will get a little idea about what to do and what not to do, which you may develop 10, 15 years later, but maybe after listening today, it may start off immediately from your practice tomorrow. If you ever feel that surgeons don't know about what anesthesia is going on, let me be very clear, surgeons know everything and they expect the anesthetist also to know everything about the surgery. So if I do some cases day in, day out, like I am a bariatric surgeon, so I've been doing only bariatric surgeries for the last 8 years. I know what happens during anesthesia. I know what drugs they use, what relaxation is given, what is TOF monitor. We know all this. So whenever an anesthetist will say like, no, 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 patient is relaxed, I can definitely ask them, can you check the TOF monitor? So don't be taken aback by the awareness of the surgeons, especially those who do the same kind of cases day in, day out. So we know that in these select cases, like in bariatric surgery, what agents are going to be used, what agents will not be used, what analgesia will be used. Those kind of things the surgeons know. So if you feel you will give normal saline and say, oh, I gave a top up, they come to know when that happens. So don't underestimate this aspect about surgeries. Same surgeries, if we are going to do over a period of time, we will know that, okay, this aspect or this component the anesthetist didn't do correctly, or at this stage the patient woke up or not woke up and he was moving. We can anticipate it. So these are the things that you should have in mind, and this can only be taken you can get rid of them by being very honest about it.
So, my first question to you is, since you're doing your own private practice, Dr. Amrit, when you have to choose an anesthesiologist, what are the key qualities that you look for in an anesthesiologist before you hire them for the case? And also, once you've met with them, then, to call them again for a case. Because this is very important from a freelancer point of view, how we project or portray ourselves to the surgeons so that we have a long standing relationship with them and they don't just call random different anesthetists all the time.
So, one thing is we don't really see what are your degrees, where you did your anesthesia from that much. What we care more about is a little bit about your work experience, but more than that, how available you are. So, if we call you for a case and you are like, oh, I'm busy with this person or that person, or oh, I'm having these prior commitments, then they know you're not reliable, you won't be counted upon again and again. So, that is number one. Other is when you come for the case, if it is a medium or a low risk case, we don't want too many investigations to be asked, or we don't want the patient to be troubled that okay, he needs to get his pre-anesthesia evaluation done. Then you ask for things. So a lot of things in private practice the surgeon will do at his own end. So when we do bariatric surgery, we know these are the high risk patients, and before the anesthetist will ask, I will get his 2D echo done or his PFT done. So in most cases, when I'm asking someone to come, I feel that they should know that okay, not many things are going to be asked. They should be available, and of course, the performance in anesthesia undoubtedly is required. Most anesthetists are good anesthetists on the table, but what also matters is how they handle the patients in the pre-anesthesia, and of course, a little bit in recovery.
So, can you tell me, like, starting from induction to recovery? Suppose I am coming to give anesthesia to your patient for the first time. How will you judge me as am I a good anesthetist or am I not so good anesthetist? So, what will be your points where you will, tick, 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 give marks to an anesthetist?
Yeah, so these kind of calculations are going on in our mind from the start, no doubt about it. When how it starts is the first time you see our patient. Are you going to ask for things while they are going to get induced, or are you going to calm them down a bit? If the anesthetist talks to my patient, says okay, I am the anesthetist, I will be giving you anesthesia, a little calming influence, because surgeons are always in a hurry, they don't even have the time to talk to their patients on the day of the surgery. So if they do this little extra before, tick, that is the first tick. Second tick, of course, is how they are precise with they are taking IV lines. Like bariatric patients, IV is very difficult. So
Hmm.
IV lines, arterial lines, neck lines, the induction process, how calm they are.
Hmm.
Because many anesthetists will, induce the case comfortably, but not make the surgeon comfortable and patient comfortable. They just go about doing their job. Surgeons are noticing all this. Like, are they keeping the OT environment at ease? Intraoperatively, of course, we look at the relaxation. Patient should not move. The blood pressure should be at a certain level. Different surgeries require different levels of blood pressures. How smoothly the person recovered from surgery. These are the obvious things, but the subtle things are how much does the anesthetist help me during the surgery apart from just keeping the patient under anesthesia?
Hmm.
Like senior anesthetists who have worked with us in the same kind of cases, if we get stuck at a certain stage, the surgeons are so into that mentality that okay, this has to be done, this has to be done. Sometimes we are lost. We do look to the anesthetist to rescue us, at least give some inputs. So we don't take you as okay, you are on the other side of the patient and you are only going to give anesthesia and keep them under. We also look for surgical advice. Like, okay, do you feel this part needs to be sutured, or does it need to be clipped, or is the hemostasis looking good? Those kind of surgical contributions are also expected from the anesthesiologist. If things go, like if the surgery is getting delayed, it happens. Like many times we encounter, unexpected complications during the surgery. Now, instead of me dewashing and going and asking or informing the relatives that things are getting delayed, I tell the anesthetist, will you go and talk to the patient's relatives? They never say no. But if you start saying, no, this is not my job, you have to talk to the patient's relatives, of course, it will put the surgeon off, because then he has to dewash, go, explain, come back, wash up again, and restart. They need
Hmm.
a little peace. when things are going wrong, that should come from the anesthetist side.
Basically, you want them to help you along with keeping the patient well anesthetized and stable. And but
The
I
whole
have
deal,
a
yeah.
question about this. Does it involve picking up your mobile phone calls, messages? मैं ये hospital में आ रहा हूँ, वो hospital में आ रहा हूँ. Because many surgeons do this. They keep their phone on ringer and they expect you to pick up every call. Now, I have no problem doing that because I love talking anyways. But the problem arises when suppose my patient is coming out of anesthesia, out of relaxant, and I at the same time I have to give relaxant, and there is a call coming, and then some surgeons get pissed off if you don't pick up the call. So, what do you think about that?
In most of the private and corporate hospitals, there is a lot of technical staff who answer the calls. So we leave it to them. It's only when they are not there that we expect the anesthetist to take the call. But and let me tell you why. Every surgeon feels every call is a future patient's call, right? So they feel patient is calling for an inquiry. So if I miss the call, the patient may go to some other surgeon. They don't want that to happen.
Oh,
तो
so you
जितने
don't
कॉल
know
आए,
these secrets.
yeah, it is all mathematics and calculations that they are doing. That if I miss the call, the patient, it may be a patient who may go to someone else because I missed it. Oops. That's why they get irritated, if you don't take the call.
Okay, so that is one thing that I wanted to ask you. Another thing, out of all the things that you mentioned, you said that you are going to see how meticulous an anesthetist is going to be in anesthetizing your patient, like in the beginning. How well they put the IV, how well they intubate. But all patients are not very easy. Sometimes it may take time to put an IV, it may take time to intubate, and you don't want to rush things because you don't want to create a mess. So, do you think the speed at which an anesthetist induces makes a difference to the surgeon कि ये बहुत slow anesthetist है या ये बहुत fast है? Or is it okay if we take some time but do things properly? Like, since the time I have started my residency and so on and so forth, I've always seen anesthetist saying jaldi karo, because the surgeon will get pissed off that we are taking so much time to induce. So, is that a correct perception or not?
I would say 50-50. At some stages, the surgeons do expect a bit of urgency when they know for themselves that these kind of patients at least look to be easy cases for anesthesia induction. I'll give you an example. When we do bariatric cases, some patients are 30-32 BMI, which is not a very big patient. These kind of patients, we expect that there should not be too much of difficulty in finding IV line, securing the airway, and inducing the patient. So in these patients, if things are getting delayed, surgeons do get irritated as to why is it happening. And then they start wondering, is it because of lack of meticulousness or the anesthetist being over precautious and still taking their own time? But yeah, of course, if it's a high risk case, a 50 BMI case with sleep apnea or ischemic heart disease, then we don't want you to rush because we have come with a mind mentality ready that okay, this case will take 3 hours. So if the anesthetist takes a little time to induce, it's fine. But if a case we expect to finish in 1 hour and the anesthesia time is taking 30 minutes, that does irritate the surgeons, no doubt.
Okay. Another point of contention between surgeons and anesthetists, when anesthetists cancel the case on table. So, they'll suddenly say that yeah, this investigation is not there, or these ECG changes were not there in the patient, or the patient's BP is very high. I've tried everything, the BP is not coming down. I don't think it is safe to anesthetize this patient in this kind of setup. Sometimes you're working in smaller setups. So, how does the surgeon take that? What do they think? And do they feel like, Array, next time we'll not call this anesthetist because they ask for too many things and cancel cases on table?
So, really speaking, most of the problems which are avoidable should be identified preoperatively and not on table.
Hmm.
So, if a person has gone through the process of PAC and these things were not picked up at that time, then the surgeon is very well aware that this is an avoidable last moment cancellation. But yeah,
Hmm.
if something pops up unexpectedly, like unexpected ECG changes, then the surgeon accept it. So it
Hmm.
works both ways. But something missed on PAC identified intraoperatively or just before inducing, of course, that in private practice means a lot of resources are lost because patients are paying from their pockets or their insurance even to get admitted. let alone undergo the procedure. So patient most likely will not come back to the surgeon. So that means a loss for the surgeon, which is what they feel.
Okay. All right. So my next proper formal question to you is, how important is communication between a surgeon and anesthetist during the surgery? Because there are some times, I'll give you an example. Sometimes just after induction, I've given general anesthesia, and when the surgeon takes an incision, the heart rate goes up. It is expected. There is going to be a painful stimulus, it will go up. And I've seen some surgeons immediately reacting to the sound of the ECG, saying, why is the heart rate suddenly gone up? Now, I don't want them to sort of question my anesthesia every time. So, sometimes, we prefer that y'all don't comment on every change that is happening on the monitor, because we are exactly there to take care of that situation. So, but sometimes, yes, when the BP is dropping, when there's no reason, if the patient is desaturating suddenly, and I feel like, okay, give me 5 minutes, stop the surgery, let me check, I would communicate with the surgeon, but not at every point which can be managed. So, how do you think this communication between surgeon and anesthetist should be? Should we inform you of every change that is happening during the surgery, or should we not inform you at all and manage things ourselves, or something else?
No, so it's not so simple. It works both ways. But let me put it in an example manner. You said when you give the incision, the heart rate goes high. As long as it is not affecting the surgical process, the surgeons don't care. Yes, some of them may react, but those are usually, that speaks of the surgeon, not of the anesthesia or of the patient. If a surgeon is unnecessarily reacting to every change in the monitor, he is overdoing it. An experienced surgeon who is working with the same anesthetist every time, they know the anesthetist will take care and will only inform when something is drastically wrong. I'll give you one recent example of starting a surgery. So we were doing a achalasia surgery, and the moment we gave the pneumoperitoneum, we were three surgeons operating, and we were okay. We gave the pneumoperitoneum. We were about to put the other ports, and then the anesthetist told us that just wait 1 minute, deflate the abdomen, remove the pneumoperitoneum. We were like, okay. And now we have been doing this surgery so many times, we know when they say it. We immediately looked at the monitor, and the heart rate of the patient was 26, 28, 30 beats per minute. So we know that she raised an alarm when the heart rate reached a level where our intervention was needed. It was otherwise, she would have given atropine, she would have realized the peritoneal stretch is causing this bradycardia, and she was trying to handle it herself. When it couldn't be, she had to raise an alarm. So this kind of balance every surgeon will accept, but not each and every step has to be informed to the surgeon, unless you want to make them aware or you want to identify why did this happen, like suddenly BP falling, is
Hmm.
there any ongoing bleeding, those kind of things. Of course the anesthetist should ask the surgeon, but not each and everything. It will also break their rhythm, because they are like, okay, is the anesthetist so underconfident that she's asking me each and everything? But if the surgeon is topping you on everything that is happening on the monitor, it speaks of the surgeon, which unfortunately is not your fault.
Okay. So, along the same line of questioning, suppose there is a disagreement in the OT over something, intra-op during the procedure between the surgeon and the anesthetist. How do you think is the best way to resolve it?
This would normally only happen in the early stages of your practice. If you've been operating with the same set of anesthetists for, say, 3 years, 4 years, then disagreements don't happen. Simple reason being, automatically, if you are operating the same surgeries, you know who's going to be right. Like, if arrhythmias pop up intraoperatively and the anesthetist says, I don't think it is safe to continue, an experienced surgeon will say, okay, it's time we abandon or we take a call. So disagreements don't happen when there are experienced campaigners on both sides of the table.
Hmm.
If they do happen, one person has to put his foot down, and the person who is more right has to put his foot down. Though this sounds very philosophical and unrealistic, usually one of the two are going to argue their way out and decide. So I won't say it is always going to be the surgeon who will say, no, it's my patient, my surgery, my money. Sometimes the anesthetist can also put the foot down, and it works both ways.
Okay. Now, I have a very pertinent question that many of us face in our day-to-day practice, especially when you get paid per case. Suppose a surgeon tells you, okay, there's a lap cholecystectomy, and there is a fixed amount that he will be paying for general anesthesia, and you agree to go for the surgery. Now, when you go there, you see that the patient is actually quite high risk. He has history of IHD, and you're taking a risk. You're taking a significant amount of stress and risk in anesthetizing this patient as compared to just doing a simple lap call. And if the anesthetist tells you to revise the charges right before the surgery starts, thinking that this is my fair share because I'm taking so much stress and responsibility for the same, what would you think about it? How would you approach it?
Uh, I it speaks badly of the surgeon if he is not given full information about the case to the anesthetist, because not every GA is going to be the same. Like some are going to be easy, some are going to be tricky. Sometimes, if I tell the anesthetist beforehand that okay, it's a high risk case who has had IHD and things, maybe she'll bring an assistant or an associate to help her, and
Yeah.
those charges also have to be accounted for. If the anesthetist does say okay, increase my charges, and I feel it is not worth it,
Hmm.
I would pay her whatever is him or her, whatever is the extra that they demand. But I would be very wary of calling them again, because I would be like, okay, next time, even for a simple case, they may at the last moment say, increase my fees, and it's too last moment for me to find someone else.
Correct.
So there has to be this clarity, and this communication has to be there made from the start, that whatever happens, this is going to be the rate. Low risk, medium risk, high risk should be predefined. Those are agreements that you should make before you go for anyone's cases.
So this really helps the anesthetists also who are watching us to actually communicate with their surgeon that pre-operatively only you're communicating that this is how much I would expect if your case is simple or if your case is going to be difficult. And if they say yes, then fine. If they don't say yes, then it is your decision whether you want to go at that price or not. Another thing I wanted to ask you was sometimes, the surgery gets prolonged. Like, suppose you say that I'm going to do a sleeve gastrectomy and it'll get done easily in 2 hours, which is the normal time. But it may go on, it may be a difficult sleeve, or it may get converted to a bypass because of some reason. So it ends up becoming 4 to 5 hours. Now, if I've committed to another surgeon that I will be coming for their case after your case, and I lose out on that case because your case time got extended, then do you think it is fair to compensate the anesthetist for this or not?
These things happen very rarely, and normally, if you are having multiple cases lined up, you do put a leeway. So an overlap, because you're having too many commitments and losing out on the next case, is a very rare occasion. Compensation for that would normally not happen, because even the surgeon has lost his time and the patient is going to pay the same amount. It's not that the patient's fees are going to increase. So from where will the surgeon compensate? He will have to compensate it from his pocket. If he doesn't do it by himself and you ask for it, then he would not be very happy with it. I'm being honest here,
Hmm.
because he would be like, okay, कभी 2 घंटे का 4 घंटा हुआ, but sometimes a 2 hour sleep can get done in 1 hour also. If it
Yeah.
gets done too soon, are you going to say, okay, मैंने तो कम anesthesia दी, now you pay me less? It doesn't work in reverse. So why would it work going further, getting a delay? So compensation in that case would not happen. But yeah, if you are working with someone on a regular basis, these problems don't arise. This will only happen if you're going for a one-off case. And in that time, be very clear about either this is the risk of the patient, that I should be paid this much, or irrespective of the duration, I should be paid this much. These kind of things should be clarified from the start.
Okay. Okay. Now, surgery is over and patient has been shifted to post-op recovery. What is the role of the anesthetist that you would expect? Because sometimes, anesthetists will just pack up and leave the minute the tube is out. Sometimes they may stay back in recovery, look whether the patient is having post-op pain, nausea, vomiting, he is woken up completely. Now, if you're looking to label someone as a good anesthetist, then what would you expect from them? That should they wait back in post-op recovery and for how much time? 15 minutes, half an hour, or should they be available on call? Or is it okay if we just finish our case and leave for another case? How do you think
So
of it?
So I have seen both kinds of anesthetists. Some anesthetists who leave if the patient is given spinal anesthesia, they will leave even before the patient is moved from the OT table to the recovery because they have to, run errands as they put it. So no, of course that's a strict no-no. But on the other hand, as long as the patient is had a comfortable extubation and he's in the recovery, and there are people to look after in the recovery, like in a corporate setup or in a government setup, most recovery will have staff. In that case, if the anesthetist just knows that the patient is in recovery and he is stable and they leave, that is fair. There is no timeline that they need to wait 15 minutes, 30 minutes till patient is shifted to room. That is not their job. That is the job of the recovery staff. Places where there is no recovery staff, either the anesthetist or the surgeon, someone from the medical team should wait till the patient is shifted to the room.
Okay. So suppose you are looking to choose an anesthetist to have a long-term relationship with. What are the key qualities that you will look for in them? Like suppose, you're in your initial, right now you're in your initial phase of surgical practice and you want someone who will work exclusively with you for at least for the next 10-15 years. So what are the key qualities that you would like to look for in them?
Uh, First is if they have exposure or experience in the branch that I have done, they should be available, not just for my routine cases, but if things go wrong. The performance in anesthesia over time, even if they didn't have experience, will improve. I don't worry about that. But more than that, they should keep a OT environment calm for the patient and for the surgeon, which unfortunately many anesthetists don't. So I have worked with so many anesthetists in the last 10, 15 years where some of them are so aggressive or hyper. I don't know why. It maybe it's a part of the job. It puts stress on the surgeons also.
Hmm.
So the environment that they create should be a calming environment for everybody inside. And when
Hmm.
they feel the surgeon is losing control, they should come over and take control. So it happens in our cases many times, like when we are doing a bariatric surgery and some instrument is malfunctioning, then the surgeon gets very irritated. He starts abusing everyone. And
Hmm.
that time the anesthetist should take over to
Hmm.
create a calm environment, maybe by shouting at the staff why this is not arranged. When the surgeon is calm, if the surgeon is not calm, the surgery will go for a toss. So
Hmm.
that is something that we look for, some extra support. Not just your job is not just induce the patient, extubate the patient, done. That is not how it should be. In today's day and age, it should be a complete surgical cooperation, including knowing what surgery is going on in terms of the steps, what to anticipate, what complications can happen. So when we are doing achalasia or upper GI surgeries and we are dissecting in the esophageal areas, so anesthetist should anticipate that okay, there can be a injury to pleura, there can be a pneumothorax. So if the surgeon sees that okay, she's auscultating, she's looking at the saturation, that means she's aware. Simple things. When the surgery is getting over, automatically they should elevate the blood pressure so that the surgeon can look for hemostasis. It should not be that the surgeon is asking for it.
Correct.
That oh, what's the blood pressure? So
Hmm.
these kind of surgical contributions more than just giving the anesthesia is what will separate you from a normal anesthetist. Anesthesia, everybody learns over time. Surgery, also, everybody learns over time. But these extra little things are what will maintain your ties forever with a reliable surgeon.
So, Dr. Amrit, can you tell me, because you mentioned this multiple times, that you would want the anesthetist to know about what are the steps of the surgery. So, how important is it for an anesthetist to have a knowledge of a particular surgical procedure? Because very honestly, many of us in the initial phase of our anesthesia practice, we like to go on the surgical side and look at what are the steps, what's happening. But over a period of time, because it becomes so routine and we sort of, I mean, I'm talking about myself here, but we become little lazy. Then we'll be like, okay, I have to give either spinal, or I have to give either G, or I have to give a block. Whatever the cases, this is what anesthesia I will give. And we tend to overlook the steps that are happening, whether it is an orthopedic surgery or a general surgery or laparoscopic. So how important do you think, and I'm asking this because every day he asks me the steps of the surgery that I have anesthetized. How important do you think is it for the anesthetist to have knowledge of a specific surgical procedure that they are inducing? And can you give
I,
an
I will
example of the same?
I will put it in just one line. If you are not aware of the steps of the surgery, of what is going on, you will never be able to anticipate the complications and prevent them. You will only be tackling them once they occur. And if they have occurred and you are tackling, you are a normal anesthetist. But if you can prevent them from happening, then you are a great anesthetist. So you have to, if you know the steps, only then can you anticipate what can go wrong. Simple example, in bariatric surgery, we have to put a tube from the mouth into the stomach. It's like a Riles tube. It's a very thick Riles tube.
Hmm.
And this, when we put, we staple the stomach along the tube. So that's how the surgery is going to be done.
Hmm.
If I don't know when the surgeon wants the tube to be inserted, to be moved, at what step, then what will happen? Surgeon is operating, he's reached that step, then he asks the anesthetist, doctor, now pass the tube. What will happen at that stage? The anesthetist will hunt for gloves. Then she'll wear the gloves. Then she will adjust the light. Then she will adjust the head of the patient. Then she'll tell the assistant, okay, give me the gastric tube, the bougie. Then he'll hunt, open. Then she'll put the bougie. 5 minutes are lost. Surgeon's mind is, racing as to why was this not ready. If you
Hmm.
know that this is the step where I'm going to ask you to pass the bougie, why were you not ready? So
Hmm.
these kind of things, they seem very small, but they make a big difference. And then 1 hour surgery will become 2 hour surgery, and then you will ask for compensation.
I think everything at the end of the day boils down to compensation. Okay. Now, we have spoken a lot about elective situations, you being able to choose your anesthetist, call them in elective situations. But what about emergency situations? What is your expectation in an emergency case from an anesthetist?
Uh, if it's an emergency, it is something uncalled for. Surgeons are already very stressed, so they are not going to bother too much about the environment around. At
Hmm.
that stage, what we expect from the anesthetist is bare minimum. Just keep the patient stable, keep them safe so that we can perform and tackle the complication. If possible, provide inputs and bring the patient out safely. In emergency, we are not worried about performance and time. We are more worried about patient safety, and everything, the outcome in the end should be good. That's it. So, about emergency, not so important in terms of performance at every step. It is more about keeping things safe.
Okay. Can you discuss the importance of trust and reliability in the surgeon anesthetist relationship? I think this question is, I don't know, it's difficult to describe. It's more like asking, can you describe trust between a husband and a wife? But yeah, like if I'm telling you that yes, the BP is down, but there is a reason for it and I will get it up, then do you trust me or no in that situation?
See, the fact that we have never operated together, it means that element is not built in us yet. But no, initial practices, the trust is not going to be there. So if you go for a surgeon's case, the same surgeon's case, maybe 5 times, 7 times, they will be still a little reluctant. But
Hmm.
yeah, once they are comfortable with you, then the trust will be there. Like now, the anesthetists that we operate with, we don't even wait to take their permission about shifting the patient in. We just tell them, you take the patient, you induce. We are very sure. Earlier on in our practice in high risk patients, we would be waiting at the head end, seeing them use their CMAC to put the tube in the correct place.
Hmm.
It sounds a little outrageous, but we used to do that. We used to see that, okay, have they intubated in the trachea or has it gone in the esophagus? That was the, I would not say element of trust or element of mistrust. But
Hmm.
over time, this anesthetist is reliable. So the trust develops. It's a time bound process. You automatically are going to approve your work. Some surgeons will say, ऐसा नहीं है. It develops over time.
What do you feel about, in the initial years of anesthesia practice, because we want to make our name be known to every surgeon, we tend to overcommit ourselves and take too many cases in a day or commit to too many surgeons that I will be there. So, what do you feel about anesthetists doing that? Because it is important to establish yourself initially so that one surgeon or two surgeons then repeatedly keep calling you. Would you want to call an anesthetist like this who's running around the whole day, or would you not want to do that?
The first question that you asked me was the qualities we look for in an anesthetist, and my answer was availability. So, someone who's running around pillar to post to complete 10 cases in a day is not someone I would be very comfortable with calling on a regular basis, because I would be like, okay, she is like a time bomb. She's on a clock, so even I need to be on a clock. Which, if I don't want to be, I would still compel to be. So if my sleep is getting a little delayed, patient is a little high risk, I would still have to compromise by making my speed faster. So no, that is not something I would recommend you to do even in your initial days of practice. In fact, more in the initial days, because that is the period when you will make mistakes. So ek taraf you are making mistakes, other taraf you are exposing yourself to such unnecessary scenarios. It will only affect your status in the surgical field.
So just trying to butter my ego as an anesthetist, if you prefer to work with me, would and I was not available for some case of yours, would you reschedule your surgery, your elective surgery, just on the basis of my availability?
A lot of surgeons do that, where if the preferred anesthetist, preferred assistant, preferred staff nurse is not available, they do adjust the timings of their elective surgeries. We have done it ample number of times that okay, this anesthetist is not available in the morning, she's there only in the afternoon, so we'll do it in the afternoon. So those adjustments are made for sure, but over time. For that, you prove your worth, and then the surgeon, the whole team will accommodate you so that your availability is also prioritized and not just the patient's wish.
Okay. One more question, because there are too many advancements happening in medicine, especially in the branch of anesthesia over a period of time. We now use ultrasound to put central lines. We hardly ever put blind central lines now. And similarly, even for spinal, and we have different kinds of drugs that we use now. Uh, do you think surgeons like anesthetists who experiment? Um, I would call it experiment, or rather try to learn new things and then use it in your cases, or do you prefer the age old whatever is going on, jaise chal raha hai waise chalne do, and don't play with my patients, sort of? I
This
would
depends on
play with the patients. I think that's a wrong way to put it, but rather, don't try anything new because it's my patient. If you want, you do it in some other surgery.
No, so this depends on the surgeon. New young surgeons like me are more than happy where anesthetists use newer technologies as long as it will do no harm, which I feel is the case with most technologies. So nowadays in anesthesia, in our cases, who have a very big neck and who are having sleep apnea, anesthetists use a different way of mask ventilating. They put nasal prongs for mask ventilation, which to an old timer bariatric surgeon would look a little outrageous. But
Hmm.
then the anesthetist will tell us, see, we don't have to hold their jaw up, and this will straight away go from the nose. It will not be affected by an occluded airway. So those kind of things, newer surgeons are very prone to accepting, using CMAC for intubation versus the conventional those blades that you use, the Macintosh. I think
Agree.
that's what it. So we are more than happy if you are using CMAC kind of devices, and younger surgeons will be more appreciative as long as we see some outcome difference in the patient safety.
Okay. So I think we've discussed most of the things that you all need to know what goes on in a surgeon's head when he is working with an anesthetist. I would like to invite any questions if any of you all have. Dr. Abhishek, Nikhil, Dharmendra. Some people have not written their names. iPhone Zoom user Ujwal. If anyone has any questions for a surgeon over here, or even any sort of everyday scenario that you have faced in your practice, and you would like to put forth the same thing as to how is an acceptable reaction from a surgeon for the same.
While we wait for people to ask their questions, I would just throw on a few experiences or a few pieces of advice. A lot of times it happens that something goes wrong in the surgery and the anesthetist is panicking. That is the one thing the surgeon would hate to see. At least the anesthetist, if no one else, should maintain a state of composure. It will keep the surgeon composed, and it will ensure that whatever complication has happened will be taken care of. So that composure should come from the anesthetist. Surgeons are very, they get very easily irritated because they are fatigued.
Hmm.
Standing for 3 hours, 4 hours, and things are not progressing. You are cutting the wrong vessels, wrong tissues is bleeding. They are totally getting fried in their head. The anesthetist should exert a calming influence and maybe even provide some inputs. This, not many anesthetists do. I've worked with many of them don't, but the ones who do are truly going to be appreciated. Don't feel it's not my job.
Hmm.
Patients surgery, patients recovery is the job of the team, not just of the surgeon or the technician or just the anesthetist alone. I always say the surgeon is the brain of the surgery, the anesthetist is the heart of the surgery. Both have to work in sync for the surgery to happen safely.
I think that's very important for us to understand. Over a period of time, we do get a little complacent that, surgeons are anyways always anti-anesthetists. It's never like that. I have always believed that it is teamwork, whether it is marriage or whether it is marriage in the OT between a surgeon and anesthetist. It is always supposed to be teamwork. If suppose the surgeon is running late, you can speak to the patient, you can speak to the patient's relatives, calm them down, make sure that they're taken inside the OT. It's not predefined that this is someone's job or that is someone's job. You have to work as a team if you want to grow together. Okay, so do we have any questions? All right. I think we have all happy and content anesthetists over here. They don't have any grudges against their surgeons. So thank you so much, Dr. Amrit, for joining us today.
Thank
And
you.
we will be putting this on YouTube because this is a very interesting session. And I think every anesthetist should watch this session to understand what is expected from an anesthetist from a surgeon's point of view. And with that, we'll wrap this up. If you have any questions, you all can also leave it in your comments and we will make sure to answer it. Thank you so much for
Thank
joining
you.
us today, sir. Thank you.
Thank you.